morning from Miami Beach. This is Dr. John Bennett of Neurosurgical TV. This is what it's really like on the beach. We have another webcast in a series done by Y.R. Yadav, the president of the Neurological Society of India, a 12-part series, and today is part 3. And I'll let Narayan Swami, a neurosurgeon from Jabalpur, India, introduce Dr. Yadav. Welcome, Narayan.
Yeah, thank you, John. Good evening.
Sir,
Every week,
I think you have to permit Dr. Jitin Bajaj as a panelist. He has. I'm sorry to interrupt you. Please let me join as panelist. Jitin Bajaj. John, sir. And then obviously Dr. Professor Swami, please.
Yeah, good evening, everybody. Welcome you all. Again, this is the third episode of the Endoscopic series held by none other than Professor Yadav, who is a pioneer in endoscopic work. And as you all know, he is the president of NSI, and then he has devoted his life for endoscopic surgery, and he has trained more than 850 neurosurgeons all over India. He's given multiple workshops throughout India, including premier institutes. And today he's going to speak of chronic stage and evacuation. Over to you, sir.
Thank you. I think you need to, or after that, after my talk, you have to introduce the other panelist, whatever you decide, no problem. So I start my talk.
Yes, sir.
We have panelists today, Professor Vijay Parihar. He is professor in my institute. Professor Shailendra Ratre, again professor in my institute, and Dr. Jitin Bajaj, associate professor. Why I choose panelists in our place from most of them, and Professor Kodai from Chennai. He is a professor and excellent neurosurgeon and endoscopic surgeon. So we have been doing endoscopic surgery for more than 20 years. And fortunately, ours is the place where we operate 10 to 20 endoscopic surgery per week. So that's, I think, the number may be the largest in the world. And this we have been doing since last 20 years. So with this comment, I welcome all my friends and all the participants, and I am grateful to Professor John for giving me this opportunity to interact with you. So I'll be talking on endoscopic surgery. I think I'll have to go back, so I don't know how to do that. Okay, I think I'll go like this. Okay, from the beginning. Okay, so greetings from Jabalpur. This is the central part of the India, and we are working in Government Medical College. I am director of the Super Specialty Hospital and School of Excellence in Neurosurgery, and I have already discussed that we are conducting an endoscopic training program for more than 20 years from now. So regarding the chronic subdural, I'll have to place this somewhere so that doesn't come in my, this is coming somewhere. Anyway, okay. So Chronic subdural hematoma is generally, it occurs in elderly, usually treated by burhole craniostomy with closed system drainage. So this is the usual treatment. Most of the neurosurgeons do it by burhole craniostomy. But there are indications for mini craniotomy and craniotomy. There are a subgroup of the patient of chronic subdural hematoma, which are difficult to treat by burhole craniostomy and closed system drainage, which is most accepted treatment. So these cases are the multilocular hydrocephalus. So once you have multiloculations, then by a single burhole or even by the two burholes, you cannot break those loculations by blind method. So therefore, most of the time these patients have incomplete evacuations. So endoscope helps in breaking these loculations and taking out the whole of the hematoma, which we will be discussing in our video also. And obviously it is not the burhole craniotomy and closed system drainage cannot treat organized or solid clot. So once you have a solid clot or a organized clot, then a simple burhole cannot treat this. So you require a large craniotomy, whereas endoscope can do this. And if there are multiple bridging vessels or vascular membranes, which are difficult to differentiate by CT scan alone, but I think with the MRI, you can find out. But if you use endoscope, then since it is under magnification, under visualization, so you don't require, even with the CT scan, you can go ahead and treat such cases, because when you do endoscopic surgery, you will know where is the bridging vessel, where are the septa and everything. So even MRI is not required when you go for endoscopic surgery. So the indications of endoscopic surgery are that it can be done in all type of chronic subdural hematoma, but this is especially useful when the usual treatment of chronic subdural hematoma, that is burhole craniotomy, burhole craniostomy, and closed system drainage does not work. So these are the things which I have already discussed, that when there is a multiple localized in the chronic subdural hematoma, you cannot just open them blindly by the burhole technique. So you require either a craniotomy or endoscopic assistance. Craniotomy being a more invasive, endoscope is particularly very useful in such cases. And if you have a solid clot or organized clot, it does not come with the irrigation, simple irrigation. So therefore, you have to do it under endoscopic visualization, and with suction, any amount of solid clot can be removed. So it's good. And then if you suspect, or there are cases in about 10 to 15% patients, there are bridging vessels and there are vascular membranes within the cavity. So when you go for simple burhole evacuation, you can injure these bridging vessels and the vascular membranes and produce acute subdural hematoma. So there may be hematoma, and these patients have recurrence, and some of them may develop acute subdural hematoma. But if you do it with the endoscope, since it allows you visualization of the whole hematoma cavity, you cannot just injure those bridging vessels or the vascular membranes. So it is specifically useful for such cases. Multiloculated, I have already discussed. So this is the example. You see, in this case, there is a septation. There is a septa. So if you want to make a burr here, you can evacuate chronic subdural hematoma from this place, but the hematoma or other localization hematoma will remain. And if you have organized clot, see, this one is hyperdense. So this is an organized clot. If you want to go for just simple irrigation, then this organized clot does not come. It is stuck to the inner membrane or to the outer membrane. So this does not come. So you require larger craniotomy in such cases. This is again a septations. So there can be multiple septations and there may be organized clot. This is acute on chronic. So there is a chronic component and there is a acute hemorrhage. There is a laminated chronic subdural hematoma. So one chronic subdural, then there is a layer of acute subdural hematoma. So these patients obviously also cannot be treated by burr hole. That is the standard treatment. So you require a large craniotomy, and this may not be good for a elderly patient because these lesions are normally present in elderly patient. So larger, the more invasive you are, you create a more risk. So with a minimally invasive endoscopic surgery, these are the ideal candidates. And if, if there is, you see here, there may be breathing vessels. There may be just breathing vessels in the cavity itself. So if there is a breathing vessels and you just blindly irrigate and try to take out the hematoma, then these breathing vessels can bleed and can produce acute subdural hematoma. Because you are doing endoscopic surgery under vision in the whole hematoma cavity, so you can coagulate it and cut the breathing vessels, and therefore you avoid development of acute subdural hematoma in these cases. So this is how you can coagulate the breathing vessels, and ultimately with the seizure you can just cut. And the other, obviously, I have already said that if there is an organized clot, that is solid organized clot, it does not come by any amount of irrigation which we do in the burr hole irrigation technique. So these hematoma will not come by any irrigation, or the solid clot will not come. So the endoscopic technique is especially very, very useful for such cases. Regarding technique, we go for 3 to 4 centimeter craniotomy, and the dura should be opened up to the bony margin, which I'll be discussing later on also. It is very important. If you leave some dura beyond the bony opening, then this dura will stain your endoscope. So I coagulate the dura right up to the bony margin, or maybe sometime beyond the bony margin. And I use 30 centimeter long endoscope, which is 4 millimeter in diameter. The fine and angle tip suction and the other instruments are used. So you should use fine instrument, number one, and the instrument should have an angle tip, so that the tip is visualized all the time when you do endoscopic surgery. The endoscope is usually placed at 90 degree to the floor, so that it becomes very easy to operate. It is done under air media, and initially we remove the SDH, and then we take out some of the hematoma under endoscope, and then we try to visualize the bridging vessels. If there is any vessel in the cavity, so before, in sometime, rather in majority of time, I use modified tubular retractor, which I devised. It has not been described so far in the world literature. So before introduction of the modified tubular retractor, because this retractor also can injure the breathing vessels. So don't introduce the modified retractor blindly. So first observe the hematoma cavity with the endoscope, and if there is a breathing vessels, you coagulate it and then introduce very small, small length of modified retractor, and then under endoscopic visualization, you keep on introducing the modified retractor. This modified retractor is required when there is a less space, because you require some space to introduce your endoscope and to introduce at least 2 instruments for endoscopic surgery. So if there is a less scope, less space, which occurs when the hematoma is thin or in a young patient. Even if the hematoma is very large, the brain is tight. So the moment you remove part of the hematoma, the inner membrane bulges there. So only partial removal of the hematoma is possible. So in such case, I use modified tubular retractor to see the distal part of the hematoma cavity, which I'll be showing later on. So it is important to use modified retractor in some case when the space available for introduction of the endoscope and the instrument is less, which I'll be showing the modified tubular retractor, how I design it. The proper site of the burr hole is very important. It should give straight trajectory, because I use rigid endoscope. In flexible endoscope, the vision quality is very poor, number one. Number two, the working channel through which you try to aspirate is also very narrow. So it is practically impossible to aspirate the solid clot. So therefore, it is not a good idea to have flexible scope to remove chronic subdural hematoma, although some authors have described it, because the advantage of flexible scope is, see, this is the example. Suppose if you use flexible scope, then you can curve it and go right down posteriorly. You can visualize the whole thing. But the disadvantage of the rigid scope is that it goes straight. So when it goes up to here, then you cannot visualize the distal part. So I thought of something which can retract the brain, and this is how I devise a modified retractor, which will retract, soft retractor, which will retract the part of the brain along with the curved suction tip, and you can visualize the hematoma cavity right from when you introduce it from here. You can visualize it up to here. So the incision should be at the most rostral part and the curved part of the brain. This is very important. I want to take some time. See, if you make a burr hole here, for example, if the clot has come right up to the midline, and if you make burr hole, so by any master surgeon, you cannot just go and take out the hematoma cavity. When you go straight, you will go straight in the brain. So you should be at the most lateral part and the curved portion, which can be either anterior. So this should be either in the frontal region. This is not the site where you should make the burr hole, which I have shown in the red arrow, because if you make burr hole here on the red arrow, then you will enter in the brain. So it should be at the most lateral portion and the most curved portion. So by using a straight endoscope, you can visualize the whole of the hematoma cavity, except the portion which is posteriorly placed and in which the brain is coming in your view. In that case, I use a curved suction tip, which I'll show in my operative video, and the tubular retractor, which can retract the, dynamically it retracts the brain, and therefore you can visualize the most posterior portion. So you should visualize whole of the hematoma cavity and remove the whole hematoma. Never ever go for blind aspiration of the hematoma. There may be breathing vessels and you can have bleeding from here, and then it is impossible to control it. So always do things under endoscopic control. So either you make a burr hole from the anterior side, that is frontal side, or the posterior parietal. If the hematoma is not reaching there in the frontal region, then you go from the posterior side where it is coming and remove the hematoma. If it is not there in any of these situations, not coming here, not coming posteriorly, then you should come from the superior side. See, this is the inferior side of the skull. This is superior side of the skull. So laterally on the most curved portion, superiorly, you should make a burr hole or a 3 centimeter small mini craniotomy, and then introduce your endoscope and go anteriorly and posteriorly and inferiorly and remove the hematoma. So the position of the burr hole is the most important place, most important point in the surgery. And second is that you should save the outer inner table towards the hematoma. If I make a burr hole here, then if this is the opening, then I must drill the inner table towards the cavity so that my endoscope can go very easily. And I should also drill the outer table on the opposite side so that the endoscope can go very well. The keyhole craniotomy should be at the highest point, as we do in all surgery. If the lesion does not extend to the transition zone, that is either anteriorly or posteriorly or superiorly. So these three sides are the ideal side, because making a burr hole on this side, you can reach the whole hematoma cavity. But there may be situations when hematoma does not reach either anteriorly or posteriorly or superiorly towards the convexity there. In that case, you require little larger incision, because in that case you have to go this side and that side, but never ever go for burr hole craniotomy on the thickest portion, which we usually do it in the burr hole craniotomy. Wherever there is a large, thickest portion of the hematoma, we make burr hole there. But in endoscopy, you have to be on curved portion, most lateral, either anteriorly or posteriorly or superiorly. So this is very important. Therefore, I am taking time. And this is what is very important. If you have a cavity here, and if you want to go straight there by the endoscope, then you drill here, that is opposite side, and you drill the inner table towards the cavity of the skull and outer table of the skull on the opposite side, so that your endoscope goes straight in the cavity as shown here. So this is just a diagrammatic representation. The outer membrane and the dura should be coagulated right up to, this is the bone, the mini craniotomy done, and this was the dura. So you have to coagulate it right up to the bony margin, not that just you make a cruciate incision and then all the time your dura will be staining the endoscope. So coagulate the outer membrane and the dura right up to the bony margin. I go even a little beyond that, so that it does not stain my endoscope. There are two methods to reach at the distal part of the hematoma, which I partly also discussed. See, this is the chronic subdural hematoma, and it reaches even beyond the convex margin of the brain. So if you want to go by the rigid scope, you can possibly reach up to here. At times it goes right up to the posterior margin. So it is practically impossible to see this portion. And by using a curved suction, see here, you can see that the curved tip is retracting the inner margin of this is the outer margin, this is inner margin. So the curved dissector is retracting the brain so that you can visualize the most distal part of the brain. And another method to do that is the curved suction tip. So use curved suction tip, and the convex part of the suction tip also retracts the brain. Means brain and the inner membrane. So you can retract it dynamically, and you use modified tubular retractor. I introduce it right down to the most posterior portion, and then with these suctions, I retract dynamically for very short period. So I retract, it is a soft tube. So I retract it so that I can visualize the most distal portion, which is very important. So you can use modified retractor to allow you to reach up to the distal portion, or you can use angle tip instrument. The convex side of the suction or the instrument should be retracting the inner membrane to allow you to see the distal portion. And this is what the modified tubular retractor which I devised. There is a tapered end so that it is good for ease of introduction. So you put this portion inside, and this can be of any length. It can vary from 3 centimeter in length to maybe 5, 6, 7, 8 centimeter, depending upon the length of the hematoma cavity. And I used to initially use just a simple tube, but with the introduction of the suction and other instrument, it used to migrate inside or outside. So to prevent migration of this tube, I applied these 3 sutures. So if these 2 sutures, when you apply, it does not allow migration of the tube inside and outside. And this central suture does not allow migration of the tube inside. Even if it migrates, then you have these sutures, and because of these sutures, you can remove this modified tubular retractor. But this tubular retractor is very, very good. So there can be situations when you come across the breathing vessels which may be very distal. So you may not be able to reach these breathing vessels using straight instruments. So if it is not possible, then you can use a curved suction coagulation, or I devised again, I innovated, I use the infant feeding tube, which is insulated, just the VP shunt wire, and then it can be, angulated the way you want. So, and only a tip is non-insulated. So once you pass the current, then the bridging point or bridging vessel can be coagulated and cut, or if there is a hematoma, or if there is any bleeding anywhere, that also can be coagulated. So this is a very useful thing which is not available in the market, but you can make it because the curved bipolar forceps are not available. But I think with passage of
Video demonstrates endoscopic evacuation of a subacute subdural hematoma. A 30-year-old chronic alcoholic male presented with a GCS of E1, V1, M5 with both pupils normally reacting. The CT had revealed a thick subacute SGH with more than 1 centimeter midline shift. The hematoma was having intervening acute components in the clot. The special instruments included a 0° 4 mm thick 30 cm long endoscope, an endoscopic bipolar, angled suction, and a modified tubular retractor. A 4 cm incision was made over the anterior curving part of skull so as to let the endoscope pass along the long axis of the hematoma. The operating room setup is shown here. A 3 by 3 cm craniectomy is done. It is essential to achieve perfect hemostasis before opening the dura. It is coagulated and opened up to the bony margins. A modified tubular retractor is placed to protect the brain. The endoscope is placed alongside it. The hematoma is sucked under direct vision. Irrigation helps to loosen the clots. Here we can see a bleeding vessel. It was possible to coagulate it using
You want to
endoscopic
see
bipolars
the modified
under vision.
retractor, which is there. So breathing vessel also.
The endoscope is slowly advanced and clot is progressively sucked. The angled suction is an excellent device in narrow areas. It should be angled away from the brain and should be gentle over the dura. The modified tubular retractor helps to retract and prevent brain injury. It also helps in keeping the suction spatially oriented while irrigating. Here we have evacuated the clot even posterior to the parietal convexity. The endoscope is angled cranially and more clot is being sucked out. These clots were not coming out through irrigation and had to be sucked out directly.
So for the solid clot, you need direct suction. This does not come with the.
The angled suction was again very helpful here. After irrigating and confirming hemostasis, the cavity was filled with saline. A suction drain was kept subgaleally. Care was taken to pass it across the bony opening. The postoperative CT scan demonstrated complete evacuation of the hematoma and good expansion of the brain. Patient made full recovery and postoperative course was uneventful. Thank you for your attention. Video demonstrate.
So this is another video of the chronic subdural hematoma so that you can make out. This was a chronic subdural hematoma. This is post-op CT scan, which shows a small opening and complete evacuation of the hematoma. The small opening of about 3 centimeter, and then you coagulate the. See, you can see that this is all organized hematoma. So initial coagulation and then coagulation of the dura right up to the bony margin. And after this, the suction, curved tip suction is used so that this is an organized clot which will never come by irrigation. If you make burhole cranial. So organized hematoma or solid acute on chronic subdural hematoma are the nice indications. See, this hematoma is all organized. You cannot just take it out by simple irrigation. So curved suction tip helps in taking out these clots under direct visualization. And this again is curved suction tip, retracts little bit of brain dynamically so that you can reach up to the most posterior portion. There was some bridging vessels on the right or left side of this, so that we coagulated and After coagulation, I told you that do not introduce modified retractor unless you are sure that in the field there is no bridging vessel. So we introduce this modified retractor, and then with the help of, it is an edited video, but we have uh, retracted it and reached up to the posteriormost margin of the hematoma cavity, and the whole hematoma cavity can be visualized, and you can irrigate it and suck it. So the complete hematoma evacuation is possible using endoscope, which is not possible with the burr hole. So solid organized hematoma, bridging vessels, and when there are septations, then it is especially useful. You can, we put the bone flap back and then close it with, I routinely use the subgaleal drain, which I found in a large study which we conducted in our center. We found that subgaleal suction drain has many advantages, and now it is worldwide known that in burr-hole craniostomy also you should always use drain. If you use drain, the chances of recurrence are less. So the advantage of endoscopic approach is it can be used in all cases, but in the following cases, it is better suited. If you have organized or solid clot, if there are septas, when there is a recurrence, then it is better to use endoscope, and it prevents injury of the bridging vessels or the synechia or the membrane. So you can coagulate and cut them under vision so that there is no acute hemorrhage. You can also coagulate the outer vascular wall. At times there are thick vascular wall which may be the cause of recurrence, that can also be coagulated, and unfortunately I don't remember any recurrence. We have been doing it for quite some time, I think more than 5 years, but we have not seen any recurrence, although there have been one death because the patient was already in a poor GCS. So the surgery was not the cause of that death. The higher percentage of hematoma removal, the complete hematoma can be removed, the better visualization of the hematoma cavity, whole cavity can be visualized. So whatever you are doing, sucking the things or blind, I mean, nothing is blind, it is under vision, and it prevents craniotomy for lesions which cannot be removed by the burr hole. So these are the conditions. Organized hematoma cannot be operated by simple burr hole, subacute or acute hematomas or multiseptate hematomas. In all these cases, you can prevent craniotomy. So these are some of the example preoperative scan and the post-op small opening and complete evacuation. Again, preoperative chronic subdural hematoma, post-operative complete. This is again a preoperative on the right side and post-operative complete hematoma removal. When you have a young patient with a tight brain, then we use tubular retractor, modified one. So you can see that it is a solid clot plus in a young patient. So once you remove little bit of hematoma here, the brain bulges. So you cannot see the distal hematoma cavity. So if you use this modified retractor and retract the brain, then you can visualize the distal portion. So it's excellent. I mean, it is very, very useful in young patient, thin SDH, and in a tight brain. Again, In this case, you have bilateral sort of solid clot. So endoscope is especially useful in such cases. So there are advantages which I have discussed already. The placement of the catheter for irrigation is easy. You can under vision put in catheter and irrigate it and remove the clot. Pre-operative MRI is not required because you are always in doubt when you use burr hole that if there is a neomembrane or there are septas which cannot be picked up by CT scan. So in that case, you are always worried that if you blindly irrigate, then these neomembrane or septa which are vascular may bleed and can produce the hematoma. So you like to go for MRI, but in endoscopic surgery, there is no need because you can visualize them by endoscope. So just by simple doing a CT scan, you can operate all these patients. Better removal of neomembrane, solid and organized clot, good visualization of the cavity with understanding of pathophysiology. I have already seen that the inner membrane is never a vascular. If you have a clot, solid organized clot, you can very well suck it nicely. It doesn't bleed because it is not vascular. It is always a outer membrane which is vascular. So I think in time to come, we can understand the better pathophysiology of the disease. The endoscope with the help of silicone retractor helps in better visualization of the cavity and removal of the clot when there is insufficient space due to re-expansion. So either there is already less space or there is a sufficient space, but you remove it partly and the brain expands. So then you have no space to go distal to that hematoma cavity and you cannot remove the whole hematoma cavity. In that case, this modified retractor is very helpful. It helps in high percentage of hematoma removal, coagulation and cutting of vascular membrane and the septa, and it prevents injury to the brain and the membrane. So the endoscope, when you put in straight instrument, you can, if you put in blindly, you can injure the brain or the membrane, but under visualization, it is not there. The vascular outer wall also can be coagulated, but there are limitations. There is a learning curve and there is a significant learning curve. There is 2D image. There is unnecessary in some cases, in simple uniloculated liquid hematoma, it's a simple liquid hematoma. So in that case, a simple burr hole is good enough. But the duration of surgery also, when you use simple burr hole and also in the endoscopic surgery is almost same. But the opening may be a little larger than the simple burr hole. The duration of surgery is more initially in the learning curve, but now for me it is same as that of the burr hole evacuation. There is a difficulty due to rapid re-expansion of the brain, and there may be insufficient space. So it is difficult to put in three things: endoscope and the two instruments for bimanual dissection. But to overcome this difficulty, I devised this modified tubular retractor, and with this, this limitation is overcome. There is a risk of damage to the cortical surface and the membrane if you are not careful by the endoscope or with the cannula. And it may not be ideal for simple hypodense and liquid hematoma, which we have already said. So may not be as good as for just simple chronic subdural hematoma. So what is my the flow diagram for chronic subdural hematoma recommendation? If it is a small diameter symptomatic SDH in a young patient, then I use endoscope and I use semicircular retractor. If there is a large cavity, large hematoma in an elderly patient where there will be sufficient cavity, there is no need to put in this modified retractor because the cavity is already enough. But now I use even retractor in these cases because the irrigation becomes very fast. I just keep irrigation on the retractor and blindly I keep irrigating and so the work is done very fast. So to summarize, the endoscopic evacuation of chronic subdural hematoma is effective and safe option. The burr hole should be placed at the most lateral and the curved portion. I said because otherwise you will not have the endoscope should pass most of the length of the hematoma cavity, rigid endoscope. Therefore, proper planning of the burr hole is important. Dura should be opened and coagulated right up to the bony margin. The fine and angled suction and the other instruments should be used. Modified tubular retractor is especially useful when there is a less space in thin SDH and in a young patient where the brain is tight and even if there is a cavity, large hematoma, it tends to bulge the moment you remove part of the hematoma. And it is especially useful when you have a trabecular pattern. There are multiple septas, making it multilocular, and therefore it's difficult to remove all the septas by usual technique. And in presence when there is a new membrane, vascular membrane, and when there is a solid or organized clot. I'm thankful to my teachers. Thank you very much. So I stop sharing.
Okay, Narayan?
Yes, sir. Thank you, sir.
Thank you.
Sir, thank you for the wonderful elaboration. Again, you distinctly told, how exactly chronic hematoma can be dealt and the problem of recurrence can be once for all reduced. And you also gave the exact technique of how exactly to do it. And you also said one good thing, there's no use of MRI. Once you can see everything openly, it's a wonderful technique, sir. Thank you for it, sir. We are joined by eminent panelists for this discussion, along with Professor Yadav, sir. We have Professor Kodeshwaran, who is from Chennai Medical College, Kilpak Medical College, Chennai, and Dr. Jitin Bajaj, who usually works with, assists this surgery with Professor Yadav, and Dr. Shailendra Ratre, who has credit of more than doing 100 of such chronic subdural hematoma. So we will all be grateful for your vast experiences and then the discussion, sir. We have some questions in the, some participants have asked the questions. Sir, they have asked something like, that in case if the posterior part is still not accessible, what would you like to do, sir? Professor Yadav, sir, and other panelists.
So I said using these two techniques, using a modified tubular retractor, you can put that retractor, and because it is a silicone tube, so it does not harm. So I use that tubular retractor, and with the curved suction tip, I retract the brain. And then I advance that tubular retractor further down, and with the help of this tubular retractor and the angled convex side of the suction, retracting the brain, it has never been a problem for me. I have come across hematoma starting right up to from the frontal region and going back in the posterior parietal and going up to the midline posteriorly. So those all hematoma can be removed. There is absolutely no problem.
Thank you, sir. I hope your question is answered. And Dr. Lay Rahman wants to know if the inner membrane is very thick. Is it possible to do through endoscopic, or should you supplement with something else?
Yeah, so I think I was also thinking of these things, but what I found is the inner membrane is not an issue at all. The inner membrane, even if it is thick, it is because of the organized clot. And it is never a vascular. So because the inner side of the arachnoid membrane. So it's never vascular. So never ever, I mean, you have not to be scared of this. Initially, I was very careful, but now I know that it is not vascular. So I just simply try to, with gentle suction, I try to take it out, the solid hematoma, it comes. Inner membrane is not vascular, it does not bleed. So don't worry, you just take the suction near that inner membrane and take out the organized clot. It is always the outer membrane which is vascular and which is cause of recurrence, and that you have to be dealt, you have to deal sometime when it is very thick. People have even described very thick vascular membrane doing the middle meningeal artery embolization. But with the endoscope, you can also coagulate them. This is another advantage of endoscopic surgery.
Okay, Dr. Rahman, hope it's answered. You know that the outer membrane is thick and the inner membrane can just be peeled off, as Professor Yadav was described. So, the one more doctor is asking, say suppose when you're removing the cavity and when you enter from the frontal burr the posterior aspect of the brain bulges. So any technique to tackle it, sir?
Again, same thing. I use modified brain retractor. It is a silicone tube. So gently push it in and use the convex side of the brain, convex side of the suction, and retract it, and you will see the posteriormost portion. I have never ever come across the distal portion of hematoma cavity not being visualized.
So if there's a bilateral chronic STH, Dr. Rahul wants to know which one to evacuate first, or is it simultaneous? Is it possible to set up two endoscopic?
Yeah. So we get this situation, and this is a very relevant question. All of them were obviously very practical. When there is a bilateral chronic subdural hematoma, I expose both the side simultaneously. Remove the bone on both sides and also remove the dura and outer membrane up to this. So let the hematoma come of its own and suck it whatever is possible. And then I remove one side, because there are cases when you say that one side hematoma has been removed, there have been instances of bleed because of sudden decompression. So I decompress, open both the sides simultaneously, and then work, after partially decompressing both the side, then I work on one side and remove the whole hematoma on one side, then I go on to the opposite side. So simultaneous removal is important in bilateral subdural hematoma.
Thank you, sir. Dr. Mrudul wants to know if the patient has disproportionate cerebral edema, then does it form an indication for chronic, the endoscopic evacuation?
The disproportion edema, if you have, then you should suspect empyema. In chronic subdural hematoma, there is no edema. So if you have, unless the patient has come to you very late and you have some infarct of the PCA or something like that, otherwise, if there is a edema in the brain, suspect empyema. That means there is an infection. So in that case also it can be done. I mean, you have to ask your anesthetist to relax the brain, and gradually with the tubular retractor and convex side, you can negotiate and take it out.
Dr. Mrudul also wants to know if the frontal burr hole is large, how do you manage it cosmetically?
What? Frontal burr hole? Yeah, so we don't do burr hole. We make a mini craniotomy and we replace that bone flap back.
I hope that answers Dr. Mrudul's question. Dr. Rahul wants to know, have you come across any case where the modified silicone retractor has produced any retraction injury?
No, not at all. It's a silicone tube, which is 1.5 millimeters, a soft tube. It does not. It folds on itself, but don't force it. I have already said that you introduce the small length, maybe 1 or 2 centimeter under endoscope control, and then gradually you keep seeing the distal portion, gradually advance it further. And this is how, not that you put the whole length 6-7 centimeter of modified tubular retractor inside. So under endoscopic visualization, you advance the modified tubular retractor.
Thank you, sir. And then I'm sorry, I only get abbreviations, so I do not know the full name. It comes as SM, Dr. SM. He wants to know what are the indications for using rigid endoscope versus flexible endoscope.
Flexible endoscope are also being used by some of the authors, but one is that the image quality is so poor, especially when you do advance it. Focal length is also very small. It's difficult to do surgery. And when you have a solid clot, you aspirate it through the working channel. So the flexible scope is small. The working channel is still small. You cannot just aspirate the solid clot from there. So why do it? There are, there are better methods of doing. There are people, I am aware of the literature, people use flexible endoscope. And the reason of using flexible endoscope is that they thought that it is difficult to go up to the posterior margin of the clot because the brain comes in your way. But we found the answer. What I want to suggest is that there will be difficulty in surgery. You start surgery, and then when you have difficulty, you find solution that how I can overcome the limitations of that particular thing. So combined, I have a combined endoscope and a modified tubular retractor, and all the limitations of rigid endoscopic surgery can be overcome by using these combinations of endoscope and the tubular retractor.
Dr. June wants to know if the patient has more of chronic stage only in the posterior aspect, so would you like to put the patient in prone position?
Yes, yes. I told that if the hematoma is anterior, then you enter from the anterior side, or even if it is anterior to posterior, then I also use anterior. But if it is only posterior and not coming up to the anterior surface, anterior side, then obviously you have to make burr hole on the most posterior side, but again on the most curved portion and the most lateral, so as that your the endoscope can reach the maximum length of the hematoma cavity. Or see, you can put it from anterior side, you can put it from posterior side, but there can be situations when it is neither coming anterior or posteriorly on most curved portion. Then these hematomas are going, I think you are visualizing my head, so it is coming on the top of it. So make burr hole on the most curved portion on the top side. You cannot make it from inferior side because there is no, there is nothing there. So from the top, so these are the three preferred side: most anteriorly, most curved portion, most posteriorly on the curved portion and the lateral, or superior portion on again on the most curved and lateral portion. But if by any way the hematoma does not reach any of these three sides, then you have to make burr hole at the site where the hematoma is. But in that case, the craniotomy, mini craniotomy has to be little larger because it is a flat surface. You cannot go, but in such cases, and let me tell you frankly that I have not come across such type of the hematoma. When the hematoma is large, obviously it reaches either anterior or posteriorly. If it is a small chronic subdural hematoma going like this, neither reaching anteriorly or posteriorly or superiorly, in that case you can make the little larger opening on that flat surface and take it out.
Thank you, sir. Dr. Ahmed Najjar wants to know, is this technique used only for chronic STH? Is this technique tried in acute condition also?
Yeah, it can be used in acute cases, but I don't advise you to go for this technique in a young patient. See, it's difficult to negotiate. There's hardly, you were talking about cerebral edema. If it is an acute subdural hematoma, there's cerebral edema, the space, at the moment you remove hematoma, the brain will bulge. And so in a young patient with acute subdural hematoma, do not try. But if the patient is elderly, where there is a lot of space and brain atrophy, in that case, people have done the removal of acute subdural hematoma with endoscope, and I have also done 2 cases. So it can be done in elderly, where there is a sufficient space for you to introduce your endoscope. So that means a solid clot in an elderly patient can be operated.
I hope Dr. Ahmed got his answer. He also wants to know that, is there any limitation in using simultaneous endovascular technique if required?
Endovascular means, middle meningeal artery.
Probably he hasn't specified, probably he says means so.
It can be, yes, if required, if you feel that there is a outer wall, because to be very frank, coagulating the whole outer thick wall is very difficult, and sometimes it bleeds, and the present the bipolar forceps, or even, and therefore because the present bipolar forceps is not curved, so therefore I devised this curved infant feeding tube to reach at the level where there is a bleeding outer wall. But I found sometimes problem. You can put in Abgel there or Surgicel to go for hemostasis. But if you feel that the outer thick wall is very thick and very vascular, do not try to remove that. It is better to go for either embolization of the middle meningeal artery, or you can just clamp clamp the middle meningeal artery. Yes, that will solve the problem. Your voice, I think, is not.
Okay.
Yeah.
Sir, Dr. Sarvanan Muthu wants to know, instead of mini craniotomy for a beginner, is it advisable to go by double burr hole?
You can, if you don't want to do endoscopic surgery, then you can go for double burr hole. I'm aware that there's single burr hole and double burr hole with suction, drain and all that. But even if you use double burr hole technique, the multiloculated hydrocephalus, the solid clot, the organized clot, they do not come. And if there is a vascular septa, then you irrigate blindly. When you make a two burr hole, you irrigate from one side, and then you see that it is coming from other side. So it is all blind procedure. So if there is a vascular membrane, there is a bleeding vessel, if there is a solid clot, if there are multiple loculations, these burr holes, some single or two burr hole does not work. So the best is either you go for craniotomy, large opening, to involve all those septas and organized clot, or go for endoscopic surgery, because the endoscopic surgery is a minimally invasive surgery. Whatever you want to achieve by large incision and large opening of the head, you can achieve it with a simple keyhole craniotomy.
Before I invite all the panelists, I think Dr. Harshad wants to ask some question. Dr. Harshad, please.
Sir, good evening.
Good evening, Dr. Yadav. Once again, a wonderful presentation. You are always bringing out with some innovative techniques.
Thank
And
you,
superb.
sir.
Your technique is very good. This is a very common topic, and to me, I feel many people are just overlooking the chronic subdural or subdural hematomas and delegating it to their juniors and thinking, oh, there is nothing is to be done. What is there? Make some burhole and come out. In my experience, I have a very large experience of a subdural hematoma in last 30, 35 years. And I have done everything, small burhole, twist burhole, twin burholes, then small craniectomy, and now I'm doing a mini craniotomy in all cases. The biggest thing is the entrance of the light inside the subdural space to see what is happening in the subdural space. Whenever there is a subdural hematoma, I have found invariably there is associated membrane, inner membrane, which holds the brain inside. And there is a big space between outer membrane and inner membrane. And we keep on evacuating, irrigating. Either you put your endoscope or you can put this tube, infant feeding tube, and it comes out well. This does not happen with the only burholes. It does not happen. Now, endoscope, you have shown a very good technique how to negotiate the endoscope anteriorly or posteriorly by giving a proper craniotomy side. Lately, I have started using, means last 3, 4 years, 4 years, I am using a loop with the headlamp. And my headlamp goes right up to the front to the back. And I do not incise the inner membrane till I'm 100% satisfied the outer membrane is not bleeding again and the clot has been completely evacuated. It is up to the sinus, you can easily see. Now this, I'm using a Zeiss loop and with that light, wonderful light. And your technique is also wonderful. I've used the endoscope in a couple of cases. And then only you try to incise the inner layer. Once you've done that completely so that the blood clot doesn't remain on the brain and incise it, and you can cut right up, as you said very clear, rightly, that it's not vascular. You can cut in front, you can go behind and let the brain expand. So I think it is very important to do a small craniotomy in cases rather than going only for a simple burhole. And my recurrence rate, as you have said very clearly, same way is hardly any after doing this craniotomy. Now earlier I used to do that Ishara Ingram's technique, tapping, keep on tapping every 2 days, 3 days, see whether there is subdural is coming, air is getting trapped. All these problems are being covered. And it is as minimal as burhole, whatever the people may say, but my craniotomy time and the burhole time is exactly the same as the same like anybody. So sometimes we are overreacting to these burholes. If we do a small burhole and the patient gets flabbergasted when we say only burhole we'll do it, just a chota drill karo and wo theek ho jayega. That's not always the case. The patient keeps on coming back. And how many recurrences may not be your recurrences coming to you, maybe going to somebody else to do it. In India, it's a private practice, patient moves around, roams around. So this is my experience. I'm just sharing with you. And of course, this endoscopic technique, what you have described is wonderful. And I also do the same thing for bilateral. I expose both sides together, try to release both at a time so that there is no chance of reverse spooning from one side, sudden decompression coming. And yes, the same techniques we are using, wonderful technique. But the most important thing which I learned today is the placement of a craniotomy to insert your scope so that you can move around inside. And of course, your silicone tube as a retractor is superb. I admire you.
Thank you, sir.
Sir.
Thank you.
Thank you.
Excellent comments. And
Yadav, sir.
yes,
Thank
yes.
you, Dr. Arshid.
Yes, sir. Yeah, actually, the subdural, basically, it is a simple disease and also it's a complex disease. So, who is getting recurrence, we don't know. The previous techniques or burhole techniques are all blind techniques. Now, the endoscope is popularly used for this subdural hematomas. As you are trying to do this endoneurosurgery chapter in India for the past 2 decades, it was a wonderful technique demonstrated by you. because you have a complete visualization inside. What is happening inside, you can completely see through endoscope. That is the main advantage of this procedure. So if there is any bleeding, you have designed few instruments like that infant feeding tube with that ventricular the VP shunt metal tube. So you can easily coagulate with this basic, you don't need to require a hi-fi bipolar coagulating forceps also. So, and the tubular retractor is also a wonderful device. So the main advantage of youngsters, they should start doing this. Otherwise, the old Burrow technique is used for a long time. But the thing is, it's a blind technique again, like VP shunt. So what's happening inside, we don't know. Even though we have some magnifying loop, everything, the endoscopic visualization is really wonderful than any other visualization. So you have control on the bleeding. The main advantage, and also decides a steep learning curve. Like experienced person like you, it's maybe easy for you because you are practicing for more than 20 years. The newcomers, they should learn this procedure cautiously. So they should properly learn this. They should have some guidance of a person like a mentor like you, and slowly this should evolve in the field of endo neurosurgery. That is my opinions.
Yeah,
Yes, your
absolutely.
point.
I think absolutely correct. See, in the initial learning time, I said I did only lumbar disc, then cervical and pituitary, and then this is little difficult because to manipulate it right down posterior, saying is all right, but it requires some experience and little bit of when. This is correct. So what I advise is that any procedure you want to do, you should know if there are problems, how to come out of it. So therefore, I did only those surgery endoscopically in which if I am caught, if there is some complication, I bring in microscope and do it. And again, here also, I mean, for neurosurgeon, if you have problem, you enlarge your opening and do mini craniotomy or craniotomy and do the things. So there is a learning curve. The sir has quite rightly said that even the loop is fine, but yes, the endoscope gives little more corner visualization and little better. The only contraindication for this, and where you have to 100% go for craniotomy, is that if there is a thick calcified inner wall. So if you have thick calcified inner wall, then you have to go for craniotomy and you have to allow the brain to expand. Yeah.
Do you do membranectomy, sir? Membranectomy, endoscopic membranectomy.
Inner membrane, I have not come across the inner side. There is a clot. In majority of time, it is an organized clot. It can be sucked very well. So whatever you see thick inner membrane is the clot lying on the inner membrane, which is avascular. Okay. So, but if that clot remains for some time, rarely, it is a rare thing. I have not seen any case so far. So if the clot remains long for very long time there, then it may calcify and cause problem. So only in that case you have to go for craniotomy, not otherwise. I have not.
What is the recurrence rate in your series, sir?
I mean, again, I know that there can be recurrence, but I have not come across. There can be, maybe the patients are going at some other person, but it is extremely rare. And as Sir Parik sir has already said, that we used to initially, when I trained from PGH Chandigarh, we used to make burr hole, 2 burr hole, single burr hole, drain, no drain. And then every day we used to put in some needle or infant feeding tube and aspirate it. It is blind technique. Again, sometime it bleeds. So all these things are not required. It is a one-time job and under vision. So it's excellent technique. I think everybody should learn this, and it is not difficult.
Yeah, Professor Kodeshwaran, Professor Yadav is reiterating to every beginners as well as to every neurosurgeon that
I
the
think
basic principles of
someone also raised the hand, so we should answer everyone. I don't know.
sir,
Can
all
you
the questions have been answered, sir. Dr.
can you-
Takeshi is not responding. He
Okay,
probably wanted to answer, but otherwise, all the questions answered.
okay.
Dr. Samuel Kaba, sir, have raised.
Yeah, I do have a question here.
Yeah,
Um,
please, sir.
Yeah. All right. So sorry. Thanks so much for this conversation. I'm actually in Ghana, and I've been doing this for over 20 years, just like you. And we do endoscopy, but not for subdural hematomas. Now, the first thing of my concern is that in my unit we do. Some people like one bare hole, some people like two to drain. I personally use the two, and I've moved from that because I technically use the SEPS, the subdural evacuation port system by Medtronic, and and the reason is that in less than 5 minutes or 10 minutes, I insert the SEPS and I'm gone. Most of the patients we do have complicated hypertension, and sometimes the kidney function test is not that good, and it takes a long time for the recovery, and they go into a different kind of comorbidities that exacerbate after you do the surgery. So, but with the SEPS, it's become a little bit faster, and you do it under sedation. Now, it's quite interesting to listen to you, and I want to know, one, whether these things you do them under general anesthesia, and how long does it take? And do you have any comparison where you can actually come out to say, all right, doing it with SEPS or doing it with regular removal, which one gives you an advantage? And I also did ask about the CT scans you showed. Is it immediate post-op or 72 hours later, or what time those post-op images? Thank you.
Yeah, we do it after the drain is out. So it's usually after the 72 hours. Regarding your the question, I mean, local anesthesia versus controlled sedation, you are right that there are patients and simple burr hole takes less time. But also, if you do endoscopic surgery, it takes half an hour. So no problem. I mean, most of the time, all these patients can tolerate for no anesthetic so far. In last 10 years, have refused me the general anesthesia for such patients. But I accept that if some patient has a very, very severe comorbidity, in that case, you go for simple burr hole and evacuation. It also works in most cases. We all know. We have been doing it for so many decades. You are absolutely right. But yes, it takes little longer, maybe 10, 15, 20 minutes longer than the burr hole. But I think that time does not matter. But I don't do this under local anesthesia, because if the patient moves head, then you can injure your brain. So it is always under anesthesia. It may be controlled sedation also, but our anesthetists always prefer to put in a tube. So it is always better. You are doing craniotomy, so they just put in a tube and then use just sedation because it is a short procedure, so it works very well.
Thank you.
Use
Not full-fledged, I mean, GA and every kind of things. Yes.
You do in only local anesthesia and general anesthesia?
No, I do it in general.
Okay.
Yeah, you cannot afford to patient to move head. If the patient moves head, then in irrigation and burr hole it can work, but not in endoscopic surgery. And especially when you are using a rigid endoscope, it will tear brain, and you cannot, you should not, never. So I say it is always general anesthesia. But it may be controlled sedation, intubated also.
Use endoscopic holder for this?
Yes. So you can ask somebody to hold for you, or it is always better. I mean, people always say that if somebody is holding for you, then it is a dynamic this thing. I don't believe. I have been doing pituitary also. I mean, there are people who say that if you use endoscope holder for endoscopic surgery, the all advantage of endoscope is gone. And I have been using it for last 20 years. Maybe I am used to it because there was no one to hold endoscope for me when I started endoscopic surgery. I was all alone. So I think there is no problem. The endoscope does better work than somebody holding for you. The person may get tired and there may be tremors and all those things. So both of your hands are free. There are problems of depth perception, but there are tricks also. I think I'll discuss how to overcome those limitations of endoscopic surgery in one of my subsequent talks. There are limitations of endoscopic surgery, and therefore you need a learning curve. So to overcome those limitations, there are ways. There is nothing which cannot be overcome. So there are limitations and there are solutions. And there were limitations which were not described, and we overcome it by describing a new technique. Like there was a blind area, when there are straight arrangement. So we found a solution, and I'll discuss that also. So, I mean, introduce distal instrument first, and then you put in middle instrument, and it works. So there will be hurdles, but there are always solutions. This is what I believe.
Yes, sir.
Thank you. I don't think any more questions are there. Can I have views of other two panelists, Dr. Shailendra Ratre, inviting Dr. Shailendra Ratre and Dr. Shailendra, Dr. Bajaj?
Yeah, all our faculty, Jitin and Shailendra and Dr. Narayan Swami and Dr. Parihar, I think unfortunately he could not come. All of them can do equally well. I mean, whatever I do it, they can also do the same thing. So it is better to have their comments also.
Thank you.
Shailendra and Jitin, yeah.
Thank you, sir. Sir, thank you for nice presentation, sir. And everything sir has covered nicely. But one thing what always sir teach us, I want to share that especially for the beginners, you should do absolute hemostasis in every step from skin up to the dura and also inside. So absolute hemostasis is very important because we should pay some time and attention for hemostasis. A slight oozing will cause problem at the end because there is cavity, residual cavity is always there. So that point is very important, as sir always teaches. Thank you, sir.
Yes, yes.
Thank you, sir. Thank you. Thank you.
Jitin.
Any more comments or questions from the panel before we close? Okay, Dr. Yadav, thank you for your time and dedication and your
Thank you, sir.
learning.
Thank you.
Thank you, everybody. Thank you.
Thank you.
Naran,
Thanks for moderating
Thank you, sir.
this.
Thank you, Yadav, sir. Thank you, Kudesharan. Thank you, Shailendra.
Thank you.
Thank you,
sir.
John, for your wonderful effort.
Thanks,
Thank you.
everybody.
Thank you. You're bringing in, yeah.
Okay,
You're
I'm just gonna
dissipating knowledge so much. Thank you.
Okay, Dr. Yadav, I'm going to show next week. Okay, this, as I said before, it's a 12-part series. We just did endoscopic management of chronic subdural. Now, is next week endoscopic management of CSF rhinorrhea, Dr. Yadav?
Yes, sir. Yes, sir.
Okay, excellent. The team is working
Thank
well
you.
together.
Thank you. Thank you. Thank you, John.
Yes, sir.
Okay.
Thank you. Thank
Bye-bye.
you, John.
See you
Thank
next
you.
week.
Yeah,
Yes, sir.
next.
Thank you.
Thank you.
Thank you.
Bye
Good
bye.
night. Good night.